So welcome everybody. We're just waiting for a few people to come in. We've got 115 people so far, so the numbers are going up, which is excellent. So maybe I can just start with a quick introduction and just to say very warm welcome to you from a very cold Stockholm. I hope it's warmer where you are. We have this afternoon a really interesting discussion ahead of us. And I think we're all really going to learn a lot. So my name is John Kinsman, and I'm the group leader for the prevention and behavior team at ECDC. And this webinar is part of the Lighthouse, the ECDC Lighthouse, which is a community of practice for the prevention of infectious diseases. And you're very welcome to this. This is our fourth webinar in a series of ongoing webinars. And this afternoon, we have three experts with us of very high status and very high standard. So we're really privileged. And we're going to hear about all sorts of things about vaccination, models to do with vaccination, structural, individual level, cultural issues that relate to facilitating and barriers to vaccination. So welcome to the webinar. Thank you for joining us, and let's have a really interesting afternoon. I'm going to hand you over now to Zach, who's going to take care of us for the next 90 minutes. Zach, over to you.
You're done. And welcome. Good afternoon to everyone who joined us so far today. I see a few people are still trickling in. But my name is Zach Desson. I'm the policy advisor at the European Health Management Association, and I'll be your moderator facilitator for today's event. I'm just going to go through a few quick housewarming tasks before we get started, before we let you hear from our excellent speakers we have today. So the first thing is that this meeting is going to be recorded, and it will be uploaded to the ECDC Lighthouse platform. So any AI note takers that may have joined you in the meeting, they are going to be automatically removed, but no worries, if you need to access the recording, it will be uploaded to the EVA platform and the ECDC Lighthouse. And as always, questions are highly encouraged from all of you. So if you have a question, please post it in the chat for either of our speakers or even just in more general sense. If you like another question that's been posed by one of your fellow audience members, just give it a like in the chat, and then we'll really be able to keep track of which questions we want to prioritize and move forward. So anticipate that after each presentation, we're going to have a short Q&A. I have obviously some questions myself for the presenters, but we want to get your questions to them as well. So feel free to post them at any time. And with that said, I'm pleased to hand over to our first speaker for today, Professor Susan Michie. She's the professor of health psychology and director of the Center for Behavior Change at University College London. So Susan, the floor is yours. Welcome.
Thank you very much. And thank you to whoever's going to share my slides. Great. Can you put it on the full mode? Lovely. Okay. I'm Susan Michie from the Centre for Behaviour Change at UCL. I'm going to talk about applying behavioural science to managing vaccination. Three main messages. Firstly, that vaccine uptake is a behaviour, and understanding the science of behaviour and how to change it should be used to inform policies and interventions to increase uptake. Secondly, need to think about understanding not only people's capability, but also their opportunities for vaccination and motivation. And thirdly, ensure that vaccination doesn't undermine other protective behaviours. So these are a couple of reports from the Behavioural Science Advisory Group to the UK government. The first one showing that low uptake was a problem, especially in some groups. And in the UK, this was very much Black and ethnic minority groups. And the second report looking into the problem of reduced adherence to rules and guidance about personal protective behaviours in the context of vaccination. Here are some reports from the WHO and from some UK sources about the issue, behaviour science and vaccination uptake, that might be of interest to you. This was a paper summarising some lessons from behavioural science, and if you can click to the next, you'll see a big red arrow coming up, showing that despite the advice of social scientists with a long history of research and understanding behaviour, many policymakers have so far paid too little attention to the role of opportunity issues such as accessibility and cost, instead focusing on capability and motivational issues such as knowledge and desire to get vaccinated. And I think this is a really important point. What does an effective vaccination management strategy require? Good leadership that engenders trust. This is absolutely key. And since COVID, there's been a huge amount of empirical evidence on this. Good communication, so people know what to do, when and why. Countering misinformation and disinformation, which I'd say globally, we were very slow on the on dealing with this during the last pandemic. We need to get a lot better. And effective community engagement. And each of these have large empirical and theoretical bodies of knowledge in psychology and behavioural science more generally. This is a living evidence review of 143 studies looking at what we know. This was back in 2021, but we'll just go through it quickly. Just had to click on. So here, barriers and enablers were categorized using the capability, opportunity, and motivation behavior known as COMBI model. So this says that for any behavior to occur, including vaccination uptake, people need to have the capability, the knowledge and skills, they need the motivation, and they need the opportunity, the social and physical opportunity. On the right-hand side is an open access free summary of the behaviour change wheel guide on the Centre for Behaviour Change website that might be of some interest to those wanting to look into this in more detail. Okay, so what the review found was that uptake was influenced by lack of knowledge, also physical opportunity, access, cost and convenience, social opportunity, mistrust around how the pandemic had been handled, and this was increased by developing social norms around vaccination. And thirdly, in terms of motivation, concerns and misunderstanding about COVID-19 vaccine safety, efficacy and necessity. Very widespread and very understandable. I think that is true of all of us. Emotional factors such as anxiety and motivation has increased by framing vaccination as a collective responsibility. And as this has been updated, the issue of trust in reputable scientific and non-scientific information became more prominent. Okay, main 7 message for communication. Show understanding, respect, and that you are interested in people you're talking to. Establish trust or encourage engagement with other trusted sources. Understand people's reasons for not having had a vaccination. Explain new evidence and situations to people. Give clear and specific advice. Address what other people think and the social pressure that people are under and how to manage those things. And 7thly, support immediate action in terms of booking appointments. So I'll just say a little bit more about these sort of headline messages. Okay, so for anybody who's talking to anybody else about vaccination, really important to show that you're not judgmental and you want to really communicate that people's questions and concerns are understood and addressed. So kind of open-ended questions like, have you ever thought about having the vaccination? If yes, what sort of things did you think about? Did you feel you had all the information you wanted? If not, might you think about it now, given the situation we're in? Establishing trust. This is key and is the best predictor of vaccine acceptance and a very good antidote to misinformation. And the kind of questions that can be addressed there. Have you had a chance to discuss your questions and concerns with someone you trust? If yes, might you be able to talk to them again, given, well, it's probably the new pandemic in our case and situation. If no, can you think of someone you respect or trust you could talk to? For example, a general practitioner, faith or community leader, someone at work, friend or family. Okay, and the understanding the reasons for not having the vaccination. Firstly, under capability, knowledge. So the three issues: is the disease bad enough to warrant vaccination? Is the vaccination effective? Are the side effects? And I think what we've found that being very explicit about the trade-offs and efficacy is important, and it doesn't harm the support for vaccination or the trust in health authorities. So I think, you know, as with everything in life, direct, honest and open communication is a good idea. In terms of motivation, beliefs, so we have both the hesitancy, which is concerns and anxiety about vaccines, and this might be about side effects, long-term harms, but also certainly in the UK, there's certain groups where there's been a history of racist discrimination, both in terms of historic, but also in terms of people's lived experience. But as well as hesitancy, there's also opposition or rejection. And this is a small minority of people, but unfortunately, they have a very large voice amplified by social media. They tend to be anti-medicine, anti-science, believe in conspiracy theories, and anti-establishment because of general distrust. The important thing, these are a small group. Really, it's about addressing those who are hesitant and counteracting these kind of disinformation tactics. Again, just find out what people's beliefs and concerns are, and don't contradict people or back them into a corner. You know, very much, you know, listening to people, working with people, addressing them respectfully. Then an opportunity. So practical issues. Often what we find is people lack time to get off work, to get to a centre, or they were worried if they did ask to get time off work, it might jeopardise their employment situation, which often is quite insecure, or too expensive to get transport to it. Lack of digital literacy to book appointments online, lack of adequate sick pay, and fear of losing a job if somebody has to take time off, if, for example, they have 1, 2, even 3 days of illness after, or not feeling well after vaccination. So these are real practical issues. So really important to try and get encouragement from organisations and managers, getting people help with getting appointments, and making sure that clinics are accessible, that there's good paid time off and adequate pay of sick. Obviously, this is a systemic government kind of issue, but in the UK, where they had clinics and vans going round to communities where a lot of disadvantaged people living, they got very high uptake. And then the final messages, explaining new evidence and situation, giving clear and specific advice. There's plenty of information that vagueness inhibits vaccine acceptance and also decreases trust in authorities. And really helping people to think about how do you deal with social pressure, which many people are under. You know, asking people, what do other people close to you think? Do you feel it would be awkward between you if you were to get vaccinated? Could you explain it to them? So very much a kind of enabling and empowering model. And finally, the importance of if somebody shows any interest or leaning towards vaccination, seize the moment. Do things there and then. If you're a GP, if you're a health professional, whoever you're a manager at work, really try and support them to make an appointment there and then, and get more information, support them to make the contact to get vaccinated. Okay, and here I'm talking about vaccine hesitance, vaccine resistors. We can move on because I've really covered that. But again, I think we've dealt with this. Oh, no, just go back. I'll just go quickly through it. Providing information that's easy to understand and make sure it's in the target group's language and media, given by trusted people and authorities. Simple, clear, consistent messaging, and being transparent about the data and science behind the policy of vaccination. This is so important. You know, people do want to know the information. They don't want to think that things are being hidden from them. In terms of opportunity, go to where people are, make vaccination easy, cost-free, and try and establish social norms in communities like in workplaces. And in terms of motivation, we can go through this quickly because I've really covered this. Yeah. So these are just some of the things that have been messages that have been shown to be effective with people. And so 3 points in conclusion, and then if there's time, I want to show one more slide, but otherwise it can come up later. So vaccination uptake is a behaviour. Bring in the science of behaviour to understand that behaviour and how to change it. And it differs according to different groups in society. You can't just make assumptions, even within countries. I've structured this in terms of thinking broadly, in terms of capability and motivation, but importantly, people's opportunities. And then always think about if people do get vaccinated, it doesn't undermine other protective behaviours. And that's my last slide if I have time. Okay, so what was very clear in the UK was that people were getting vaccinated, but they weren't getting 3 key messages. And in these 3 boxes at the bottom, you can see these messages. After receiving the vaccine, you are not fully protected yet. You could still spread whatever it is. People didn't know that. Secondly, it's important that you return again for a second dose. And thirdly, just because you're vaccinated doesn't mean that you will be fully protected, because some people are 100%, some people are 0%, a lot of people are in the middle. So it's really important to keep going with these protective behaviours, wearing masks in unventilated, crowded places, making sure buildings are ventilated, etc. And what we did, because we've got a very diverse community, we worked with some excellent people. We had this in 16 languages, and we did a script for those people who were giving the vaccination so they could just give these 3 key bits of information. We had posters up, and we also had, as you can see, QR codes that people could download, a really neat little neat little animation. Sadly, even though the work was put in, I never saw any of this actually implemented anywhere. And I asked lots of people and nobody'd come across it. So that's maybe something we can come back to. But how do we get really good scientific advice and materials based on it properly implemented at scale and at the speed that is required? Thank you. Final, some resources, but these will be shared, and then you can go to those resources if you'd like.
Thank you very much, Susan. And I think that was an excellent way to get us started. I think that COM-B model is not only applicable to vaccine uptake, but also to many of the public health challenges that we face. There's several questions in the chat, and I will come to those. But the first one that popped up to me, especially when you were sharing these posters and sharing the story of how maybe they never actually got disseminated properly, it brings me back to one of the key factors you mentioned, the idea of using trusted sources. So I'm wondering if maybe there's a way to bridge the gap. So how do public health authorities identify and leverage trusted sources within the different communities? How do we know who is a trusted source? And how could we, maybe using the example of those posters, take these trusted sources and help get the message out there?
Well, there are no shortcuts. To know who trusted sources are, there needs to be ongoing engagement with communities, so that one knows who in the communities are respected, what kind of influences people have on people. And importantly, this should be ongoing. It shouldn't just be at the time of pandemics. So, for example, in the UK, we had a very widespread network of public health practitioners on the ground who knew individual communities. They knew what their concerns are, what their strengths and weaknesses were, what risky situations were, like overcrowded sweatshops, in terms of factories. But sadly, that was really run down. And so there was only a skeleton group when it came to actual COVID. So I think, one of the things to think about is building up the community public health engagement in an ongoing basis, so there are people ready who are known in the communities, who know communities and know who would be the real trusted sources that could be brought on board at any moment.
It makes complete sense, because we hear from a lot of different practitioners across Europe that really it matters. Each community has their own leader, so it really depends on who you need to talk to and which aspects of each community, because the communities are not monoliths as well, right? So
yeah,
that actually that brings me indeed to some questions from the audience. We're going to go a bit more into the COM-B model. That seems to be an area of particular interest among our audience today. So John was asking, actually, if you mentioned during your presentation that decision makers have often tended to focus on the motivation and capability components as opposed to opportunity, and if you have some ideas why that might be.
Well, I think it may be rather a political answer. Dealing with opportunities implies resources, so if it's just what's between your two ears in terms of your capability and motivation, it can be addressed with some persuasive messages, etc. But if one's talking about opportunity, it requires investment. So the kind of things we were talking about, adequate sick pay and support, job security, having vaccination centres go to where people's communities are. These are the kind of things that require investment. And some governments, sadly, are reluctant to invest in the kind of resources that are required for disadvantaged groups. What I'm talking about isn't relevant for people who are fortunate enough to be in, better paid or professional jobs like all of our jobs. And so, I think it's governments who don't have the interests of the most disadvantaged communities at heart, who then will ideologically be more attracted to the capability and motivation kind of arguments.
Indeed, that actually answers another question, which was, we see capability and motivation as these low-hanging fruits. The idea that maybe the resources don't need to be as high to address these issues as they might be for really addressing the more, let's call them systematic or systemic issues that might present themselves on the opportunity side of the wheel. But Dana asks, and we can continue, I think, on this theme, that is opportunity more straightforward, but maybe less resource than capabilities and motivations? Or are there really difference between the three factors across cultural, geographical contexts that we need to consider? So perhaps in one country with high resources, opportunity may be easier to deal with, but in another setting, it might be that capabilities and motivations are.
Yeah, I mean, none of it's straightforward. And part of the point of COM-B model is to give a kind of simple, usable framework to try and think in a very extensive way, comprehensive way about what are all the enablers as well as the barriers to any particular behavior. And it's, I always talk about behavior in context. That's what that model is. But the model is saying that you need all of these three things together. You could have all the capability and all the motivation in the world. It's not going to happen if you don't have the opportunity. And the same is true for the others also. So yes, it'll differ totally, even within one city, in one country, you go to different neighborhoods, it'll be different. And this is why the assessment, using this kind of model for assessing and really understanding what the nature of the problem is, not just what has caused these behaviors to happen or not happen, or happen in this way rather than that way historically, but also thinking in terms of the future. What is it that needs to change in order for this to happen in the future? So yeah, it will vary, which is why one needs to do local assessments and not just jump in with a formula or a finding that's from studies at a different time with a different population.
Actually, that brings up a question that I had, because you mentioned this idea of local assessments and understanding people really at the individual level. But my question that came up as you're explaining this is, how do we best go about understanding these people? Is it through surveys? Is it through asking community leaders? Or have you found that maybe, obviously, it could vary across different contexts as well? But I'm just curious if you have some experience to speak to that.
So I would say it's not just individual, it's communities, it's organizations such as workplaces, and it's population. One has to be able to use these kind of tools to address every single level and work at every single level. And I've now forgotten the particular question you asked. Oh yes, the methods of gathering data.
Indeed.
Yeah. So there's no one source of data that is without problems, and it very much depends on what do you want to know and so what your question is and who you're trying to get data from. One of the things is with surveys or with individual interviews, often there's what's called the social desirability bias. So people will answer questions in a way that they think is the right way of answering, the socially acceptable way of answering, the way that, maybe the person asking the question wants the answer to be. And obviously that's not very helpful. Focus groups, if it's done well, where you have facilitators that get a conversation going, but really try and withdraw, tend to get much more valid data, because then you get people talking with each other, and lots of things emerge that wouldn't necessarily in one-to-one. But because every kind of data has its strengths and its limitations, the idea of triangulation is really important. Triangulation means use more than one type of data to answer a particular question. And then if you get the same kind of findings with different kinds of data, it just gives you more confidence that what you're coming up with actually reflects the real situation.
I mean, I think those are some great pieces of advice and some great ideas for reaching different local populations and local communities and really understanding them. But I'll challenge you with a question from Ludmila that takes things even to a bit more complicated level. And it's how do we explain this process of needing to understand, this process of needing to consider all three factors from this model when we're talking about designing interventions and communicating? How do we explain that to people who work at public health institutions, people who work in governments whose thinking and processes might be a little bit more rigid? So Ludmila shared the example of in the Czech Republic, they're usually focused solely on medical or organizational aspects of vaccination and really neglect the social part of the process.
Mm-hmm, mm-hmm. Well, it's a bit like what I was talking about, the principles of communication when you're talking to people where you're trying to encourage vaccination. I mean, it is a behavior change problem. So a lot of the things that I mentioned, certainly when I work with policymakers who have a different mental model, who maybe start with not really being on side with maybe the way I see the world, it's the same things as I was talking about before. Listen to them, be respectful, start from where they are and try and elaborate and support and extend what they're saying. And the best thing is if you can get them to say what you want them to say. So you lead them along a path, building on and reinforcing the good things they say so that they don't feel you're threatening, they don't feel you're opposing them. And then, they begin saying things which are kind of the things you want to hear. And so you can say, as you were saying, and then try and get them to own what they're saying. So I think it's very much a collaborative, try and get a collaborative approach. Don't come in with saying, I know all the answers. Really try and build on what they're saying, but extend and build and shape in a kind of gradual way. And I found that to be an effective way. I give a whole talk to the people on our behaviour change MSc on working with policymakers, where actually we use it as a behaviour change intervention and use the COMBI model to structure the intervention in terms of working with policymakers.
And perfectly said, because luckily enough, we actually can move on to our next guest, I think, now and give you a little bit of a rest until our discussion later, because our next guest will really be discussing these collaborative efforts and these ideas in a bit more detail. So I'm pleased to invite our next speakers to the floor. We have Professor Marijn de Bruin and Dr. Matthijs Lamboy. Marijn is a behavioral scientist and professor of behavioral medicine and health psychology at the IQ Healthcare Radboud University. And Dr. Lamboy is a sociologist, senior researcher at the Dutch National Institute for Public Health and the Environment, and associate professor at the Erasmus School of Health Policy and Management at Erasmus University Rotterdam, so both in the Netherlands. They were both highly involved in research into the behavior of society during COVID-19 pandemic, and worked on the Corona Behavior unit. So welcome, gentlemen, the floor is yours.
Thank you very much. Thanks for that introduction, Sagari. Good afternoon, everybody. Thanks for joining. I'll be presenting the slides. Let me pull them up. Here we go. And then I'll move you to the side, Sagari, otherwise I can't see anything. Yep.
Let's take it.
Are the slides visible?
They look good.
Yeah, excellent. Okay. Yeah, thanks. Yeah, we decided to make this a duo presentation because Matthijs and I, we both worked intensively at the Public Health Institute during COVID times on the topic of vaccination. Matthijs has worked there for many years longer than I have. And the Public Health Institute in the Netherlands is very closely involved in trying to get scientific evidence translated into public health policy and practice. So we thought this was a nice opportunity to reflect on how did we try and get this behavioral science evidence into vaccination practice, and then as a case study use the COVID times, because this is quite clearly delineated and a lot of things were happening. So we thought this could be a good moment to reflect on what we've learned from that. And Matthijs and I will be bouncing between slides. Sometimes he will say something useful, and sometimes I will do that. So let's start. So the setup of the talk is as follows. We'll use the COVID as a case, and I'm just trying to get you to the side because I'm not seeing. Yeah, now I see my entire slide. So we've reflected on what we've done during the COVID pandemic, and we found that there were many routes, practical routes for trying to make relevant contributions to the vaccination campaign. I'll shortly explain how these vaccination programs were organized in the Netherlands, because that's quite context specific. And what we'll then do is that we'll run you through a number of examples that illustrate different ways in which we tried to get our behavioral science evidence implemented at different levels of the campaign. And then we'll go to lessons learned. So we identified during this pandemic different relevant entry points for behavioral science, and it's at the policy level, at the communication level, and at the level of logistics. I won't go through these now in detail. What we'll do is that we'll provide you some examples at each of those levels, and then reflect on those. So for the context, the organization of the vaccination campaign, if you look at the whole system, it's actually quite complex. So in the Netherlands, we have a health council, and this health council is comprised of top experts from many different disciplines who advise the government on what type of vaccination to provide, to offer to citizens, the eligibility criteria, the recommended order of vaccination, the frequency of vaccination, and all these sort of things. So this is really the design of the vaccination campaign. And then the Ministry of Health makes decisions about implementation and financing. Then in COVID times, we had the National Core Team of Crisis Communication, the NKC, and they were responsible for the national communication campaigns. Outside of COVID times, this can be either at the Public Health Institute or at the Ministry of Health, but in crisis times, there was a special crisis communication department who was responsible for that. And then the actual vaccination program was at the Public Health Institute, the RIVM. So they did lots of the logistics, lots of the software, the invitation letters, all these sort of things at the national scale. And then all the way down in the communities are also the municipal health services. And they do lots of the local and regional logistics, communication, implementation, and they actually do the actual vaccination. So there's a lot of levels in the organization where a behavioral science contribution might be relevant. So in the corona pandemic, the Public Health Institute helped us set up a behavioral unit, the Corona Behavioral Unit. And we were trying to keep in touch with all these different parts of the organization. And on the background, our information was that we had continuous mixed methods research. I'll tell a little bit more about that in a minute. And then we had an expert committee from across the Netherlands who was also advising us. So we're really trying to be this linkage point between all this knowledge and translation and implementation in the vaccination campaign.
And
the
if
challenge
I could add,
yeah,
the question that was asked before on how do you implement all this? We were at the center of this, and it meant talking, and because of the excellent work of Marika, who's also here, and of Marijn and of others, we were having access to all the meetings of all these institutions and all these councils. So you would start off the day talking to the National Health Services about all the stocks and the uptake and everything. Then you would switch to, I don't know, the Amsterdam region to talk to about them. And it was all about talking, exchanging, and getting all the information from all the fields, and also getting it into our excellent team who was doing all the research with all the methods, and just constantly crossing all the information. And it was just a lot of talking and a lot of meeting.
Now that's a good point. Relationship building, we'll get back to that, is really important. So another thing was that the Corona Behavioral Unit did not have a formal role in the organization. It didn't exist before the pandemic. So there was a lot of ad hoc. It was based on goodwill and this relationship building and attending lots of meetings and building visibility and trust as an advisor. And our role in this process was really being an advisor. And this Corona Behavioral Unit, we did lots of research. We kept track of the literature, surveys, focus groups, and we had this expert committee. And we also did some pragmatic trials during the pandemic. And we made lots of different documents to guide all these decisions and all these recommendations. And we had different ways of disseminating these findings to the communication professionals, to the policymakers, and so forth. And what we'll do now is that we'll give a number of examples of what that looked like at different levels. So the first thing is that at the level of the policy. So I explained a couple of slides ago that we have this Health Council in the Netherlands, and both Matthijs and I, we served as expert members on that Health Council during COVID-19. And it is a committee with epidemiologists, virologists, a lot of biomedical experts, and we were advising on eligibility order, the rationale for the vaccinations. So a lot of the decision making there is very biomedical and epidemiological, but our contribution was very much with regards to making visible what then the pros and the cons were for different target groups of vaccination, so side effects and the effectiveness of the vaccination. And so I think for us it was important that we were able to contribute to these recommendations, which then seeped into further communication by the government. Another thing that we did from quite early in the pandemic is that we developed this framework for vaccination uptake. And we basically had 3 building blocks in this framework. The first building block was that it was important to provide trusted information, be transparent about the pros and cons of vaccination, using trusted sources, allowing people to ask questions and get answers. There were motivational components, of course, that are relevant, and that people were facilitated in getting vaccinated. So this links very well to the presentation that Susan has just given. And the idea with this framework that we developed is that we were trying to set the stage. So we communicated this framework to all the stakeholders at the different organizational levels that I just discussed. So from the Ministry of Health to the vaccination campaign, to those doing the national communication campaigns and so forth. And we did that with memos, webinars, lots of informal discussions. And of course, when you present a framework like that for the vaccination campaign, it's very difficult to determine what exactly the impact was on the vaccination campaign. But we did think it definitely guided us, but also many others in how they approached the target group and communication about vaccination. Although we also had some challenges with some policymakers who were much more about top-down and instructing people rather than allowing people to make their own informed choice. So, but this was one of our key pieces of work that we delivered and repeated at every occasion to all those involved. Another key piece of research that we had was an early qualitative study. What we found in that qualitative study that there were three key motives of people to get vaccinated. The first was to protect the health of others. The second was to protect their own health. And the third was to get out of the pandemic. But then if you looked at the order at which vaccination was scheduled, it was actually quite logical on the one hand. So the vaccination order was first to vaccinate the high-risk group. And then when the high-risk groups were vaccinated, it would go down by age. So all the way at the end, it would be the young people. But they face quite a dilemma because once it's their turn, all the high-risk people had been vaccinated. The hospitals would be emptying already, and they have quite a low risk to their own health of COVID compared with other groups. So actually, by placing them all the way at the end of the vaccination order, you force them in a position to make a decision about vaccination when, you know, there's not really a key motive anymore for them to get vaccinated. So we try to bring this to the attention of the key stakeholders. Again, we wrote a memo, we did webinars, and we had informal discussions. But this behavioral insight, we couldn't get it implemented. It was too late in the process. The whole vaccination order had already been set up. And when we monitored the uptake of vaccination in young people, you could clearly see that this was lacking compared with the other age groups as well. Matthijs, you will give some other examples on our work.
Yeah, another aim of ours was to help apply the behavioral insight into mass campaign, and the time scale of developing the campaigns were quite short. So we took the instrument of our experts' opinion, who were able to get into Zoom discussions as well as quickly as possible to interact with the communication experts of the Ministry of Health, who already did a lot of the work and also had made the adverts and the clips. And then our experts, who were also guided and instructed by us, and also especially on what Professor Michie also said on the capability, on the opportunity, and on the motivation. And we asked our experts to reflect on these three aspects all over again in every aspect of the adverts, of the video clips. Then we had some iterations, and our communication experts, dear colleagues, would add it, would alter it on our experts' advice, and we suppose it improve. But also here the impact is really difficult to assess because there isn't any comparison group. But what was striking, there wasn't any harsh criticism, which could be an indication that it went good. Then we also were pretty closely involved in the invitation letter, and yeah, during the first wave, we the Katie Milkman yeah, nudge, the vaccination nudge. There is this vaccination waiting for you was out there with an outcome of yeah, 2 percentage point increase. So we thought, well, we have to implement this in some kind of way. So we also we got into contact with all the communication experts and said, this is an opportunity we have to take. So in the end, after some meetings again, the Milkman nudge was in the national letter. Also later on, our excellent team was involved in also redesigning and the other invitation letter of the boosters. And what they excellently also did was to look at the results of our questionnaires, of our interviews, on the motivation, on the opportunity, on how eager the people were. And with this framework, they scanned and systematically analyzed all the communication outlets and also the letters. And what you see here on the right-hand side, or the middle of the screen, is one of the letters of the boosters, and all the oranges were adaptation of ours after the communication experts had made up this draft. We were also able to do some testing and yeah, further yeah, make perfect, I hope, the letter. So it was a constant iteration of our team and the communication experts just talking to each other and helping each other, advising each other, and also being open to one another, which was also nice. Then also the access or the convenience, which was also emphasized by Professor Michie. We also found that, and so how to make it as easy as possible. And we were stressing this also for 1.5 to 2.5 years. If it gets easier, the more people will come. And in our studies, we also found that 2 out of 3 people prefer to make an appointment as a commitment device, and a third they want to be free to be able to match it with other obligations, with their work, with picking up the children, I don't know what, but they want it to be free. These results of ours we yeah, communicated with the webinar, with the memos, but also with the presentations to the municipal health services. And I think this was one instrument that was quite helpful. We had once a week these yeah, walk-in hours where I sat in with all kinds of healthcare professionals in the field who worked at the municipal health services, who were expressing what they had seen last week, all the problems they were facing, all the challenges they were facing, also successes. And I was able to pick it up to get a feel from the field and also bring this to our team to develop the questionnaires, to sharpen the questionnaires, to help and also to advise all the interview guides. And one of the successes or impacts I think we made was that the walk-in without appointment opportunity was created, which was quite a reorganization from the vaccination organization, but they managed, which is excellent. And also the pre-booked appointments were also offered as an opt-out device.
Okay, thanks, Matthijs. I'm just quite conscious of the time. So what I'll do, Matthijs, if it's okay with you, I'll wrap up our presentation in 2 minutes quickly. Is that okay with you? And then we go to the questions.
That's fine with me. Yep.
Yeah. Okay. So basically, I showed this slide at the beginning. And what are key entry points for behavioral science where we can make our contribution? So I think it's really at the policy level. So we try to do that at the Health Council regarding eligibility, the order, risk groups, frequency of vaccination. Is really at the communication level, from mass media campaigns to websites, invitation letters. The example that Susan also gave, that around vaccination, the moment of vaccination, there's a communication opportunity, the interpersonal communication, and the logistics. And we all see that concretely return in the work that we've done during COVID times. So these were all recommendations and advice that we gave beforehand, but during COVID, we also did some ongoing evaluations of logistics and policies that were going on. I'll briefly touch upon two. The first was that the Ministry of Health decided to, when the young people were lacking in their vaccination uptake, they decided on a behavioral strategy for which they didn't consult us. I don't know what we would have advised exactly, but and the behavioral strategy was to offer young people a COVID pass after a single Dansen with Janssen vaccination immediately after they received the vaccination, and do this at the time that also the discos were opening again. That's why they call it dancing with Janssen. And yeah, it's a very high risk strategy because, of course, immunity will not have developed yet. And but this was meant as an incentive so that vaccination uptake would increase. What happened, in fact, is that there was a very sharp rise of infections very quickly after this policy was introduced. So actually, the policy backfired completely. And what we could see is that here you see the trust in the government's COVID policies over time. You see the red arrow. That was when the vaccination campaign was going very successfully, and you could see trust increase. But then exactly at that time point is when they had this failed policy, and you could see a rapid decline again in trust. And also in our data, trust was the key predictor of vaccination uptake. So actually a policy that was meant to increase vaccination seemed to actually maybe even be harmful for vaccination because of a decline in trust. And the other part of evaluation research that we've done was on outreach with these vaccination buses. This is related to proximity of vaccination. So there were many municipal health services that went out with these buses in communities in areas with low uptake of vaccination, gave personalized information and easily accessible vaccination. And our analysis also showed that this was a highly successful strategy. And we'll share the paper for details about that. So I'll come to the lessons learned slide. The lessons that we learned from us is that there's many routes for impact. That's the slide I've already shown twice. The impact was quite mixed though. On communication, our impact was substantive, and we found that those working on the communication campaigns and websites, etc., were very receptive to the information that we were offering. In terms of logistics, we had some relevant impact, but when you're not really part of the system beforehand, as behavioral scientists, a lot of things have already been arranged, and it's not possible then to always adapt that. So we had a relevant contribution there, but not substantive. And at the policy level, it was more limited. It's much more complicated there for us to present our results. And so we think that is an important area for us to strengthen our input. And the key drivers that we were having is that it was really important that to make this contribution, that there's an expert unit with capacity on the behavioral sciences, that you have a formal place in the organization, so that you're really integrated in the web, that you have good relationships, ongoing relationship with stakeholders, ongoing research, and that you utilize an expert network of advisors throughout the country to make sure that you're providing the best evidence available in your advice. So I know we covered quite a lot of ground, but I hope that this final slide sort of pulled it together and that it makes sense to you.
To me, so thank you again to Marijn and to Matthijs for that presentation. I think it really ties together the information that Susan presented with your real practical experiences from your experiences with COVID. But of course, given that this was specific to a pandemic, and given that it's also specific to the Netherlands, I'd like to ask a few questions to help us zoom back out, because obviously much of our audience is from all across Europe and beyond. So really, I am going to take you back to that slide where you talked about how complicated all of these relationships were. You needed to have trust, you needed to have relationships and goodwill between several government institutions to really make this Corona Behavior Unit successful. So obviously that will look different in different countries, but how does that look now? Now that the pandemic, we've come to the other side, are those relationships persevering? Are there opening windows for you or doors to implement behavioral science into new vaccination campaigns, or is it more of a struggle now that we don't have that push from having a pandemic going on?
Matthijs?
Yeah. The doors are opener or more open than the pre-COVID pandemic. So we are still having the good relationships with the Ministry of Health and with the other ministries as well. Also with a lot of the municipal health service, the interaction is going extremely well. I also notice this awareness amongst a lot of the policymakers that behavior is related to health, also lifestyle and other kinds of choices. But compared to the COVID pandemic, then everything was more open. There was this urgency. Everybody was understood the urgency. Everybody we talked to also experienced on the personal level being restricted and all that, and society was closed. So it is less open than in the pandemic, but it is more open than prior.
Yeah, and we have also some additional opportunities for ongoing research to inform this. So there's a program called SocialFax, which monitors uptake and perceptions, beliefs for the childhood vaccination. And there's also some communities of practice with the municipal health services. So there's more than before the pandemic. But yeah, it's all much more hierarchical again. I don't know if you recognize that, but it was quite flat during the pandemic. You could very easily access lots of people and committees. And now it's back to the paperwork hierarchy a little bit more, which has also positive sides, but also some challenges.
And that will bring us to a couple of questions actually from the audience, because Irina asked really about the governance structure of this Corona Behavior Unit. Does it exist underneath the authority of a public health authority, or was it really a kind of unique entity that can provide behavioral science services across the response? And I'm going to tack on just one more question to that, if it's okay. Just that John is asking, based on the relationships that you've built, obviously the Dutch context is unique, and you have excellent access to data and your specific ministries and governance structures. But if you were to give advice to someone from another country who wants to build these relationships, wants to have a similar unit that can provide behavioral science insights into policy making, what more broad general advice might you be able to give outside of the Dutch context?
Yeah, thanks. So the organization of it was embedded in the Public Health Institute, the RIVM in the Netherlands. it didn't exist prior to the pandemic. There were behavioral and social scientists working on different topics in the Public Health Institute, but not organized in such a behavioral unit. During the pandemic, it was organized as a program. That means it was across many different departments in the Public Health Institute, and people with relevant experience would come together to form this temporary Corona behavioral unit. Now, on the back of this, there actually it has now been dissolved in the usual structures again, but there are two new departments, one in health and healthcare, and one in infectious diseases. So there is some level of embeddedness, and many of the new staff have been retained by the Public Health Institute. So that's how that works. Building up a behavioral unit and retaining it also, which is also challenging. Also, the WHO has written a really nice policy brief on this, the Behavioral and Cultural Insights Unit Europe. And there's a couple of case studies, international case studies that the European Commission and we from the Public Health Institute have done that we can also share if of interest in the community. I mean, you really have to find some program champions, people who step forward and can build a very strong case to a decision maker. And it all boils down to a perceived sense of urgency. Does it fit my agenda? And can I reserve the funding for this? It's really boring, but in the end, it often comes down to, is there money to do this? And then you're in a field where you compete with many other disciplines and programs that could use this money. So it's really important that you have a very good business case, the right connections, and that you have some champions who go out and try and set this up. And if you then have the Public Health Institute behind you, that is really helpful, of course. So that's what happened to us in the COVID pandemic.
It's interesting that you mentioned the word urgency, because I remember you had posted the findings from your qualitative research that said there were 3 factors that really led to people getting vaccinated. And one of those was the desire to get out of the pandemic. So obviously we don't necessarily have that urgency factor anymore. So I wonder if you've had some experience or have been trying to develop some strategies to either simulate this urgency or replicate it, because obviously we've lost one of these key reasons that people chose to get vaccinated.
I mean, childhood vaccination, for example, is already something that that runs for a very long time, and for many people it's quite routine to do it, and a lot of other people do it. The COVID was, of course, quite exceptional, that suddenly lots of adults had to get vaccinated at a national scale, and so there was a whole, much more conscious decision making, I would say, by many people. But no doubt there's others here, or maybe Matthijs or others here in this call who would have an idea on how to, build motivation. And the challenges also maybe at the moment with all the mis and disinformation for more regular vaccines other than COVID. Matthijs, do you have reflections?
The most direct button to push would be urgency, but then you run into all kinds of ethical problems. So this is what we have been trying to do for the last couple of months is to interact with the policymakers, with all these stakeholders, and also bring on the cases. So some of the examples we are presenting here about access and the convenience we mentioned, and we also try to emphasize that obesity, for instance, is also kind of this problem, and we have other lifestyle issues which are also related to health, and try to make it extremely tangible, and also still use some of the momentum we have in order to tell this is also behavior, this is also health related behavior. So we have the same principles, but it's about trying to make a strong case and talking and convincing.
Susan also has ideas.
Yeah, just to add, I mean, Tedros, who's the Director General of the WHO, has just recently been saying people must not talk about COVID in the past. It's very present. And we're talking about they call it a quadra something. But, we've got COVID, we've got RSV, we've got flu, and then we've got fourth thing. And in the UK, in the last week, hospitalizations due to flu have gone up 70%, at much, much higher than last year. And I think some of this may be because lower vaccination uptake. So I think we can use the current situation, and really use the data we have on, I don't know what it's like in the Netherlands, but in the UK, the number of people who are off work now, who are not able to work, is really risen. A lot of this is long COVID, and COVID is still going around. So, these are really live issues that don't just affect health and well-being, but affect the economy. So I think we need to use all of these arguments.
I think I agree completely. When that's probably this spring we had a little local epidemic of the measles in the south of the country, and the municipal health services of those areas were also quickly to find us. So this is also a sign that we are still known out there among the professionals. We still have the momentum.
And even to build on that, Susan, I'm curious because we've talked about the idea of motivation kind of shifting, even though you're right. I understand what you're talking about with I believe the quadridemic is the term, with also pneumococcal pneumonia. And that's the thing, is people's motivations change. Now that the pandemic, it might not be, the virus is still among us, but the idea of the pandemic, I think most people have moved on from. And their motivation will also change for becoming vaccinated. So I wonder if you have some thoughts on how can we adapt our systems and the way we behave and the way we make decisions to people's motivations, which are more or less constantly changing.
They are, but motivations also related to knowledge, and people aren't being given the knowledge. I mean, we have next to no testing anymore, and we're surrounded by people who are coughing, have got all the symptoms of COVID, who say, "Oh, I've got this dreadful cold," coming into work. And so I think it's a question of, in all our different roles, whether we're workplace representatives or just workplace colleagues, whatever committees we're serving on. I mean, whenever I go to any meeting, I always ask for the windows to be opened. I use every opportunity to say, COVID is still around. A lot of infections are still around. People are getting sick. We want to reduce the number of people being sick. So I think, and a lot of people say, really? Even people you'd expect to be knowledgeable aren't knowledgeable. So I think it's just drip, 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 everybody using whatever means they have to try and keep those messages going. And I think one of the things I really agree with what Marijn was saying about there's an interaction between having some structures, keeping the structures going as best we can, but also having these champions, people who can be the right person at the right place to talk to the right people to get things going. So I think we just don't give up. We use every opportunity.
I think it speaks back to what you said near the beginning, that leadership is critical. Who is going to take the baton and put these messages out there and really take a stand and inform themselves? Because I think perhaps we can all agree at the political level at the moment, there might be a bit of a vacuum in terms of strong leadership with especially when we're discussing health issues. It's an item that's been kind of slowly pushed off of the forefront since the pandemic has moved behind in people's minds as well. So I wonder if it's a matter of finding different leaders or finding different people who we consider leaders. So it could be maybe different doctors or different community leaders, or if it's a matter of speaking differently to the leaders that we do have and just getting them to change their message. And I think maybe perhaps from the Dutch practical example, if you have some thoughts on how that went for you and what your experience was with that challenge.
So can you reframe that a little bit more practically?
Sure. Is it about educating politicians, or is it about giving the message to people who are not politicians who might be able to better deliver that message?
So there's a lot of people engaged in informing the general public about vaccination. So in the Netherlands, at least, most communication goes through the municipal health services or the Public Health Institute. And although the Public Health Institute is financed by the Ministry of Health, they are independent agency. And a lot of the responsibility for the communication about vaccination more generally is not with politicians. And given that vaccination is one of the most cost-effective public health interventions available, there's also not that much doubt about, at least not in the Netherlands, about whether or not to finance it, childhood immunizations or the flu vaccination. So usually, at least outside of the COVID times, we don't see politicians talk about vaccination in the Netherlands. It's much more done by health professionals and public health institutes.
I mean, we can go to a different level of trust then, perhaps, because we mentioned the idea that we need trusted sources to speak to, and different trusted sources are different for different communities. But do we trust the same people with health information that we trust for other information, for example? Like, would we trust a spiritual leader both for spiritual guidance and for health information, or do those need to come from different places? And I wonder what your experience, I think all three of you perhaps might have a bit of insight into this. So please, Marijn, I see you nodding. Perhaps you can get us started, but then we'll move around the table.
Well, I think it would be good if people can approach the people they trust with questions about vaccination. So that might be their GP. But another nice example during the COVID pandemic was that there was doctors set up a vaccination hesitancy phone line. So this was independent initiative of everything else. And basically they trained medical students to answer questions about the vaccine. And lots of people who were doubting about whether or not to get vaccinated called it, and they got independent advice from a medical professional. And we also saw in our research that especially when the vaccinations were just rolled out, there was a lot of discussion about vaccination by medical professionals on the TV. And from our qualitative, but also our quantitative research, we could see that a lot of people valued those reflections by medical professionals. So I feel that people do have a lot of trust in doctors for this because of their expertise and independence, because they put the patient and the health at the forefront. So I think they're a very important trusted source about vaccination.
Yeah, I agree with it. It's also my experience, and I've also heard some examples of areas where religious groups were located a lot, where the GPs and religious leaders, they teamed up and they approached the community together in order to be able to answer all types of questions at once.
I think that's a really good example. Those just independent of all the other structures, a group of doctors getting together to provide that service. I hadn't heard about it before, but I think that's really inspiring. In the UK, we had what we called Independent SAGE. SAGE stands for Scientific Advisory Group in Emergencies, which was the body of scientists advising the government. But this was an independent group, multidisciplinary. It was set up by a former chief scientific advisor, and it included clinical doctors, public health doctors, social and behavioural scientists, virologists, epidemiologists, modelers, etc. And that was set up actually to begin with just on a one-off basis, doing a YouTube broadcast. And there was such a positive response that we kept going. And every week, and then fortnightly over 2 years, on a Friday, we had a broadcast for an hour and a quarter, I think it was, where the public, journalists, politicians, anybody could come and ask questions. And we had 20 to 30,000 people joining a week at the maximum. And it had a big knock-on effect because a lot of us were asked onto the media. It was picked up a lot on social media, but because we were transparent, and when we tried to interpret as best we could the scientific evidence to address the questions that people were coming with. But then there was somewhere we actually didn't agree. So, for example, this vaccination passport, Marijn, that you mentioned, it was very split. So the medical people on our group were much more in favour of it because, looking at it from a medical point of view, that was a good thing. But the social psychologists on our group weren't so much in favour of it because it was very demographically biased. So those people, who were most disadvantaged anyway, would be further excluded from local sort of recreational settings. But we openly talked about that. We said, actually, there's different points of view here, and this is why there are different points of view. And I think people really respect that. So anyway, if anybody's interested, just go to Independent Sage website, and all of the broadcasts are there. The last one was in December, which was talking a lot about actually trust in science and how do you engender it. But again, I think that was a good model. And it's just interesting that different countries have come up with these things that actually were very influential and very popular and welcomed amongst the public. Outside the official structures. It'd be very interesting to find out what else like that happened around the place.
Thank you for sharing that, Susan, because we've had several requests from the audience to share some of the documents that you've all referred to throughout the talk. So I'm going to just confirm with our team in the background that they can collect all of these afterwards and make them available for the audience. And just coming back to this idea of balancing of messaging and different viewpoints, I'm happy, Marijn, that you did not skip the Dansen med Jansen example, because I think it's a really interesting one. The idea that if we give one message, it might in the end undercut another message. So we say, get your vaccine, it will help protect you against this disease. But obviously then some people take this as the idea that, oh, now I'm safe, I will go out and I can't spread the disease. Maybe they've missed the message. And it can be the same with our other vaccines now. If someone gets a vaccine, they're told it's going to protect your health, and maybe they feel, oh, I don't necessarily need to wash my hands, it's less important now. So I wonder how we have the ability to balance these messages, and if there's a way to measure if one thing will lead to another. Obviously not always, but I'm curious of all three of your thoughts on this idea of balance and this idea of being careful for leaning one way or the other with our communication and our decisions.
Let me first, just to clarify the Dansen with Jansen, that was actually the policymaker, the politician, trying a behavioral strategy to get more people vaccinated by offering them an immediate COVID pass the minute they were vaccinated, right? So, and that actually backfired. And because it was actually the incentive for vaccination was that you could go to if you did it on Friday in the evening, you could go to the disco. That was how it was sold. So it was very much, you can see, of course, that it is an incentive for some people, but you can also see how it's not really, taking account of the risk that is involved in that, and also how that might backfire when everything goes sideways. So yeah, that was my point. And then, because I was thinking about that, Susan or Matthijs, if you could answer the question.
Well, just on that, I mean, that's incentives for risky behavior. That's an incentive for behavior that's going to spread. They could easily have done it that you got the passport 2 weeks after the vaccination date, and that would have helped spread the message that you're not protected. So that's really poor. And we had a similar really poor thing where there was an incentive for behavior that actively spread the pandemic. And there's good evidence that this happened, which was eat out to help out. So what happened over the summer, in which it was a lovely summer, we could have had outdoor pop-up restaurants and cafes subsidized, which would have taken everybody outdoors. Did that happen? No. The opposite happened. People were subsidized. They got cheaper food and drink by eating inside premises. So if you went to a sandwich shop and ate in an unventilated, crowded, high-risk situation, you'd have 20% off, or I can't remember what it was, compared to if you bought that sandwich, took it outside and sat on a park bench where you wouldn't have infected anyone. So it's a similar thing. You know, these are actively incentivization for risky behaviors, really poor. And the unintended consequences were things like we had a curfew. Again, social and behavioral scientists not consulted about these things. Curfew, we'll shut the pubs early at 10 o'clock. So, of course, what happened? Everybody piles into people's homes, overcrowded, unventilated places, instead of incentivizing the pubs to have all their windows open. You know, you can stay open if you have your windows open and the doors open in the evening. So, you know, incentives are all very well, but they have to be used for the right things in the right ways.
Yeah, I agree. Zachary, I don't want to steer the discussion, but I think what we could see from Susan's talk is that there's a lot known about how to, you know, what makes people vaccinate or not, hesitancy, etc. But there's really, really big challenges, which is what Susan illustrated with her work with the NHS, and what I try to illustrate with Matthijs as well, is on getting this implemented. All right. So how do we get our science implemented also in these complex structures? So you need to be, you know, sort of a completely equal player. You need to be very well organized, visible. You need to have all those commissions. And if I look at the behavioral and social sciences in the Netherlands, you know, because it's not a professional group, like virologists or surgeons or cardiologists, you know, they're very well organized. They've got a big lobby. They make sure that they're on the right places in these organizations. In the Netherlands, at least, the behavioral and social scientists are not that well organized. You know, is that an issue? You know, is that a little bit different maybe in the UK, where you've got the health psychologists as a professional group? But I think these sort of implementation questions are really, you know, what for me, I don't know, Susan.
I think it's a really important issue. I mean, in the UK, we have UK HSA, Health Security Agency, which has a large behavioural science group. And also at Department of Health, we have behavioural science. So as a result of the pandemic, we've got much more embeddedness of behavioural science throughout government. But actually, the example I gave you was not so much behavioural science not being implemented, but health service not being implemented, because I was just the advisor on that project, and it was somebody embedded within NHS England who organised all that good work and got this really good materials, etc. But what that showed is there wasn't an implementation pipeline for that work to go anywhere in any sustainable way. So I think it's you know, even more profound about implementation generally, you know, in societies and between, you know, what we know works and actually happening in practice. And, you know, one thing is, I think it would be good if policymakers, politicians, etc., knew more that like there is a science of behaviour, there's also a science of implementation, even a journal called Implementation Science. So I think it's about where we fit in with systems, but also the systems themselves not working. And I think, you know, it'd be really good if we had a role, you know, in some way advising on that more generally.
Marijn, I have to thank you for making my job easier, because you took my final question directly from my mouth. So thank you. And I'll leave Matthijs, I think, with the last word, a bit of an answer and thoughts on implementation. No pressure, of course. Implementation and what we're missing, and some of your best ideas for how we can really implement better some of these ideas.
Oh boy. Well, yeah, I would echo the call for the organization to become an organized group of behavioral experts, and I think that helps. They're getting access to all kinds of institutions and also being heard. That also means organization, and so organizing amongst us all, and also having the means and the opportunity and the time to do the organization, because we have other jobs and other positions as well. And Ooh.
Yeah, now it's time for the really strong message, Matthijs. No, I'm kidding.
Yeah.
Yeah.
No,
No,
yeah.
it's quite complex, but I think
Mm.
Matthijs has huge experience with
Yeah.
the networking, and
Yeah.
he's been so active in both with the policymakers as well as with the public health institutions locally, and to be the linking pin in all those networks. So you need people like Matthijs who really are able to connect those different worlds. I think that is a key factor.
You
And
know what? I think
without being but I use the framework of Susan a lot because it really helps me to communicate to the behavioral experts. In the middle you have the person who has to behave in some kind of way. There are the drivers, the psychological drivers, there is this context, and you have all the policy means. So it helps me a lot, and I use it a lot to talk to the politicians and the policymakers to explain why behavior is relevant, also for the problems that they have to solve every day.
You know what? I think that's a really good place to end. So we need good data, we need good connections, but most importantly, we need good people who are working on these. So speaking of good people, I'd like to give an extra thank you to our 3 speakers today. Thank you all for your time. I hope as the audience, I saw we had over 200 of you at one point. So thank you for engaging. Thank you for your questions. I would just like to share before I pass it over to John for the closing that my colleague will be sharing on the screen a QR code and in the chat just a link to a feedback survey for these webinars. We love to hear your opinions, and we love to kind of keep adapting and updating our format as we move along. So take a moment to give that a scan, and we'd love to hear back from your feedback. And with that, I will give it back to John for some final words.
Brilliant. Thank you so much, everybody. What a fantastic performance from you all. Really fascinating, incredible insights, and really rich discussion. Heartfelt thanks. And you can see all of the clapping hearing at the bottom of the screen here. So, excuse me, many thanks to you. Really, really interesting insights. And to me, I think what we've had here is a really wonderful example of theory in practice. The COMBI model provides such a nice basis for this discussion. And I think we've seen how it can be really applied both in the UK and in the Netherlands. So really, really useful. Excuse me, speaking of coughs. Yeah, much I could say, but I think you've said it all, except that was really my main point. It's the theory and practice thing, which I think is so useful. So thank you so much for bringing everything together. I do feel like a lot of this discussion, obviously, it's been about COVID, and I think one of the key challenges we face now is to bring these lessons into other contexts, and the urgency that we faced in COVID no longer exists. So it's more challenging. It's even more difficult than it was then. So I think as we look forward, we need to think how we can bring these things into practice, even in somehow more difficult settings. So thank you, 3 speakers. Thank you, Susan. Thank you, Matthijs. Thank you, Marijn. Thanks, Zach, for chairing things so nicely. And thanks to everybody who's been here today. We've still got 100 and something people involved. Thank you for coming and for sharing your time. I'm sure you found it very interesting. We've got another webinar next month or the beginning of February on antimicrobial resistance. So stay tuned for that. I think that's going to be very interesting. And it's going to be the 5th webinar in the Lighthouse webinar series. So if you're a member of the Lighthouse, you will get information about it. And because you've been at this webinar, you'll also get information about it. So please stand by. That will come to you. And I think it also promises to be another really interesting discussion. Here is the QR code for the Lighthouse. Would you like to join? Please join. If you haven't joined, please do so. It's for anyone who's involved in the prevention of infectious diseases within the EU and who's interested in social and behavioral sciences. So scan that with a QR code and join. You can register. Make sure you fill in all the details. You need to give your profile because that way we can verify you. And the purpose of that is to make sure that we're creating a safe space for people. So please do fill in all your details. Excuse me, so you can get that done. There's the link. And with that, I would like to close and thank you again. Thanks to the speakers. Thanks to the participants. Have a very nice holiday season. Stay healthy and we'll see you next year. Thank you.